All right, everybody, and welcome to our panel discussion today here at the Future of Hearing Healthcare Conference. I am thrilled to be joined by four great guests. I have kind of going clockwise on my screen, Dr. Alicia Spoor, Dr. Kelley Linton, and Dr. Brian Greenaway, as well as Stephanie Czuhajewski. So thank you all for coming on today. I think we're going to have a great conversation. So just to kind of set the stage here, I wanted to bring these three here, Alicia, Kelley, and Brian in particular, to kind of talk about some of the different state legislation that they've been heavily involved in. As I'm sure many of the viewers are aware, there has been some state level legislation that has been passed recently to expand the scope of audiology. And so I felt that this would be a great topic for a panel to talk through the various elements of each of their different propositions, the process. And then also here with me is Stephanie, who helped to really bring this together. So wanted to give her an opportunity to talk about the role that ADA in particular has played to really support these state level initiatives. So anyway, before we dive into the topics, let's start with some introductions. So we'll go East Coast to West Coast here, starting in Maryland with you, Alicia.
Yeah, thanks so much, Dave. Happy to be back again. My name's Alicia Spoor. I am currently the legislative chair for the Maryland Academy of Audiology, and I'm also the advocacy chair for the Academy of Doctors of Audiology. So I try to do a lot on both the state and national level because it seems like seeing patients day to day isn't quite enough audiology for me. I need to do a little bit more. But I do want to make a comment first and foremost as we start, and I'm sure Dr. Linton and Dr. Greenaway feel the same way. When we talk about this, even though I'm the person here from the state of Maryland, it was really a team effort. So I'm going to call out my team really quickly just so they get some recognition. We have a great lobbying firm headed by Gil Jen with the Bellamy and Jen Group. And then there's a really core group of audiologists from the Maryland Academy of Audiology that are part of our legislative team. And those are Doctors Melissa Segev, Brianna Bruno Holton, Jana Brown, and Lee McCarthy. So again, even though I'm the token person on this call tonight, I do want to make sure that everybody knows there is a group team behind us in Maryland. So thank you for having me. I'm excited to talk about this again and super excited to have more states joining us.
Awesome, Alicia. Thank you so much. All right, moving into the central time zone, one state below me in Arkansas with you, Dr. Linton.
Yes, thank you. Thank you, Dave. I'm also very thrilled to be here with this group of people to talk about what we've done in the field of audiology. I have a private practice in Fort Smith, Arkansas, and I started that practice in 1998. I don't really particularly see patients anymore. I'm more involved in education side and industrial audiology type things and doing things like this, advancing our field. I'm a founding member of the Arkansas Academy of Audiology. And as Alicia said, it was definitely a group effort pulling the audiologists together in our state along with ADA, and excited to let you guys know what worked for us.
Fantastic. Awesome. Thank you so much. And last but not least, you, Brian, over in Oregon.
Sure. Thanks, Dave. I'm Dr. Brian Greenaway. I'm a clinical audiologist as well as an assistant professor of audiology at the Pacific University School of Audiology out here in Hillsboro, Oregon. I have been involved in legislation and policy stuff since I was a student, since someone on this call who shall remain nameless drug me into it back in Maryland. Yeah, I also currently serve as the legislation and policy chair for the now Northwest Academy of Audiology. We merged successfully Oregon and Washington academies together this year. That's been going great. And I also serve with Dr. Spoor on the ADA policy committee as well.
Awesome. Well, thanks so much for being here. All right. Well, let's kind of get into it. I think the first question is to talk about, what is actually being proposed. So if one of you, maybe we can start again with you, Alicia, to just kind of unpack, what are the changes that are being proposed and the significance of each change?
Yeah, very much happy to. And I know Dr. Linton's going to come in behind me, so don't Don't think I'm taking any thunder away. Feel free to jump in if you want to. But I do want to mention a little bit the catalyst for this. So when the FDA final rule came out regarding prescription and over-the-counter hearing aids, that was the catalyst that we used in the state of Maryland to kind of start working on this process. So we knew we had to open our statute to make sure all of our audiologists could prescribe prescription hearing aids so that we could continue to use that as a tool in our tool belt when it's appropriate for our patients. And so we use that as our stepping stone to go through, and we really harped on the comments around modernized and harmonized the practice of audiology. And the nice thing about the state of Maryland and probably many other states is that the other clinical doctoring professions have already done this. You know, we're kind of the young profession. We're the ones that are coming to the game now. And so we looked really closely at optometry. We looked really closely at dentistry. And then we also looked at chiropractic and podiatry and what they already had in statute, because that set a precedence in the state of Maryland. And so that was our kind of stepping point, but we wanted to make sure that we excluded any ambiguity around things that people would say, well, you know, can you use evaluation and management code? You have evaluate, but you don't have manage. Is that a gray area? Is it not? You know, it's nice to just have it clean and clear and ready to go. And so that was our jumping point moving forward. And as you'll hear, I'm sure as we talk about a little bit later, it wasn't immediately successful for the state of Maryland either. We just kind of got a little bit of a head start in front of Arkansas. But that was our founding point and the reason why we went about maybe including some phrases or comments around cerumen removal or prescription hearing aids or radiographic imaging, or including what was not part of the profession of audiology, because again, that was a precedent that was set in our state. So I'm going to pause there and I'm going to turn it to Dr. Linton because she can kind of go through all those little components that were added as to what was actually included in the practice of audiology.
Yeah, so we looked at things that would let our patient care be more fluid and be able to work with the other primary care physicians and other physicians that were referring to us. And these were things like being able to order blood work, cultures, imaging. Again, you know, when patients are coming to us, we have an idea of some tests that we need or that the primary care physician is going to need, or maybe the ENT is going to need. So being able to order those, have those ready to go, just helps that patient care. It's the flow of the patient care and keeps maybe the patient from having to linger to get another appointment to see the physician who is going to turn around and order the blood work or the cultures or the imaging. And then come back. So if we could step in and get those items ordered, what's needed, and then be able to send the patient with those results to the physician that they need to see, it's going to be better patient care.
That's really interesting. Okay, great. So thank you for kind of setting the stage here. Brian, do you want to talk at all about Oregon and sort of the process so far that you've been through there?
Sure. So it kind of started off very similarly. A lot of things kind of fell into place at the same time. Around the time that Maryland was wrapping up their legislation last year, our licensing board actually came out and made an announcement that they were going to be opening up the statutes and rules this legislative session to make some changes. So of course we jumped to it. We went through all the statutes, all the rules, line copy, just made a bunch of suggestions. Turns out the board, due to some staffing issues, didn't go through with their plans this year. But we decided we had good copy. We thought it was the right time for a lot of reasons, which I'm sure we'll get into later. So we went ahead. We were able to find a sponsor and push forward with a lot of the same things that we drew very heavily on Maryland. Sounds like a lot of the same things from Arkansas, kind of pushing access and affordability of high quality care was always our kind of our mantra throughout the whole thing. So we had the radiology, we had the blood work portions in there. We had very specific to Oregon language that we were able to just tweak. Something unique to us was allowing audiologists to supervise audiology assistants and doing basic hearing testing. Just really things designed at improving that flow of care and getting patients where they really needed to be as soon as possible.
And if you don't mind me stepping in, Dave, I mean, I think we all skirted around maybe what your actual question was. And so if I pull up the Maryland legislation, we were very clear that we put in the words evaluate, diagnose, manage, and treat. That is extremely important in the profession of audiology because, again, removes a lot of the ambiguity. Also lets you use maybe those diagnosis codes that we're all using to bill our patients when we're working with insurances. We took it a step further and we took the FDA language around prescribe, order, fit, sell, dispense prescription hearing aids. We also put that around external osseo integrated sound processors as well as auditory implantable sound processors. So we didn't want anybody coming back and saying, well, you can do the hearing aids, but it doesn't say anything about, the external components when we're working with our surgical colleagues. We also further went down and said, well, audiologists can conduct health screenings. We know that's so important around comorbidities within auditory and vestibular care. We know that's been an issue around Medicare patients from PQRI to PQRS to MIPS and whatever process that moves forward. And it's just good patient care because we know the ears are related to so many other things. And then we put in removing foreign bodies from the external auditory canal because there were so many times that audiologists were looking in the ear canal and we're like, oh, there's a dome, there's a filter there, from our hearing aids. But again, it was kind of a gray area. And so we wanted to make it super clean and clear. We wanted to make sure cerumen removal was called out in our statute. It was in our regulations, but we added that within our statute so that audiologists could remove cerumen from the external auditory canal. You heard Dr. Linton talk about the ordering of blood work and cultures. We also were trying very much to forward think, and I love that Dr. Greenaway kind of went one step further with supervising of the assistants, which we didn't think about, but having the whole ordering and performing non-radiographic imaging in the audiology office with that equipment. So we don't know what's coming out in the next 5 to 10 to 15 to 20 years. And hopefully we're going to be moving forward and audiology is going to continue to progress and modernize. But we wanted to make sure that whatever equipment came around, that we were able to be doing that and trained, and that was within our scope as well. And then ordering the radiographic imaging, as both of my colleagues have commented on. And then, like I mentioned, in Maryland, at least, because we looked at the other clinical doctors, we put very specific information in as to what audiologists cannot do, which is a big contention when we're talking to our AMA state chapters with those physicians and or our AAO HNS state chapters around our ENT colleagues. They need us, we need them, but we're not out there to try to do the cochlear implant surgery. We're not out there to get an MRI machine and start being the radiologist and performing those. So those were very specific things that we put in, not only to alleviate maybe some concerns that the possible opposition might have, but also because, again, there was a precedent set for us. And so we want to stay in the lane of audiology, but we know that also includes the best patient care. And so those were all of the components that we put in the state of Maryland.
Well, in Arkansas, we actually took Maryland, because they obviously were the first ones to successfully do this. We took what they had written up, and Arkansas already, believe it or not, had a pretty generous scope of practice for audiology. So we did add in the things that we felt needed to be there to get Arkansas up on the same level as what Maryland had asked for. And, did have some opposition with AMA and AAO. So we had to tweak a little bit of our wording just to make them happy. And, in the end, it's very good. We're pleased with the way it's written. It definitely expanded our scope just as we wanted to. And we also put in that we would not be doing surgery and listed very specifics of surgery. And everybody was happy. When it was done, we were all on the same page and we were all groups were happy.
I feel like that's a huge takeaway, though, is to understand how to more or less placate the opposition, if you're being honest. And so I feel like that's really good intel, and good information to have. And again, I think the spirit of this conversation is to learn from one another. I find it really interesting that you have these three, very unique parts of the country, that seemingly, are kind of have their own circumstances and all that. And yet, you've got these different similar bills that are kind of being at least reviewed and evaluated. And so I think that's really encouraging. So we've kind of talked about the what, right? Like what exactly is being proposed. I want to talk about both the why and the how. I feel like maybe we start on the why and go through, in your own sort of estimation, why are you so passionate about this? What, in your opinion, does this mean for the short, the mid, the long term of the profession of audiology? How do you envision this? I mean, is this a stepping stone into something that's, greater than this, or does it? Do you foresee it being something that's sort of fragmented like this at the state level, that maybe it congeals? I would just be curious to hear your thoughts as to, both as a state that maybe has already passed this, where you go from here, or what changes from here, and then, sort of down the ladder to if you've not passed this yet, like what are you looking at? So anybody feel free to hop in here as to what, I guess, the ultimate why this matters.
Well, I'll say something real quickly. I think there's really kind of two sides to it, as far as the why. I mean, we have the side of the profession of audiology. And as a profession, we need, I've been in the profession a long time, since the early 90s. And we used to step around owning the ear. Kind of the ear, nose, and throat doctors owned the ear and the vestibular system. And we kind of had to dance around that in the early 90s. But our profession has grown. We're now a doctoring level profession, and we need to step up as a profession and own the ear, the hearing center, and the balance system. So this is just progressing that in the way that it needs to go, so that we continue, just as ophthalmology owns and optometry own the eye, we, ENT and audiology needs to own the ear and the vestibular system. So, on that side of the profession, that's a why that we need to progress this way. And then on the other side, you're looking at patient care. I mean, why is insurance is much more difficult to deal with. They pretty much dictate to physicians what they can do, how much time they can spend, and it's getting much more limited, and reimbursement's getting, much less. We're seeing a drop off of physicians. We don't have as many physicians as we did. In Arkansas, we're a very rural state, and we actually did a heat map, and we're a 6-to-1 ratio. We're a 6 audiologists to 1 ENT ratio in our state. And patients just can't get in. They can't get in and be seen. And when they are seen, it's just for 4 minutes or 5 minutes, whatever the insurance allows them to be seen. As audiologists, we are not governed that strictly by insurance at this point, and hopefully never will be. So we can take time. We can really question the patient. We can dig deep in with questionnaires in their health, their comorbidities, and we can really get a more holistic picture of what that patient needs and get better care quicker for the patient.
And just to linger on that point right there, so what within the changes would, I guess, further support the viability of that patient care aspect? Are you talking about better reimbursement, or is it how does that actually translate into what would change from where it is today?
Well, as it is today, the patient, like if I do testing on a patient, or I visit with a patient, I'm unable to order any imaging. So I then have to write a report to the primary care or the referring physician and request that they consider imaging. And honestly, I know we've all got stories and have had this happen. You send that back to the doctor. Does the doctor really read the report? Does he have time to read, or she have time to read the report? Do they really put thought into what we've asked them to do, why we need imaging? What our worries are, what our concerns are. A lot of times they don't, and the patient just gets passed on by after they've waited 6, 8, 12 weeks to even be seen by the doctor, and then it's just dropped. And sometimes they're back at our office 3, 4 months later saying, oh yeah, I wasn't able to get that imaging, or I mentioned it to my doctor and they said they didn't really know what I was talking about and they didn't order it. So if we can clear all of that up and have those results done, it's going to be, the patient is going to benefit. We do not financially benefit from the items that we have put in the legislature. So we are not getting any reimbursement, which was something that we strongly had to explain a few times in our testimonies. We are not reaping any kickback or benefit financially from the changes in this legislature. This is strictly efficient patient care in our world today, with insurance dictating a lot of what it does for the MDs.
Makes total sense. Go ahead, Alicia.
I would further note, and Dr. Greenaway can jump in as well. Like Dr. Linton said, this doesn't help audiologists financially in any possible way. It does help the patient, and it helps our ability to provide that patient care at the highest possible level we can have. So what's really happening in Maryland, and we do have a very strong audiology base because of some of our forefathers that came around in audiology back in the 70s. We're now that we're ordering this imaging and ordering the blood work and cultures, we're able to get those results much faster, and then we're able to triage the patients that really need to be seen by our surgical and or super specialty providers, physicians. And so people always think, oh, they're going to go to ENT. Well, no, they're going to go to the neuro-otology specialist to take out that CPA tumor that was just diagnosed and is aggressively growing. That's not general ENT down the street. That is a super specialty. And we're also noticing that a lot of what we're ordering and getting results back and triaging our patients is neurology, or it's dermatology, or it's cardiovascular. Again, all those comorbidities, but everybody just always kind of thinks, ENT, send them to the ENT down the street. And that's really not what we're finding now that we've been doing this for 6+ months in the state of Maryland. And so we're able to use those results to get the patients where they need to be, or to go back to the patient and say, hey, you don't have any of these red flags. We'll continue to monitor you as the doctor of audiology, but let's get you the treatment either audiologically, vestibularly that you need, bring you back in our office, and then we'll revisit this again in 6 months, 12 months, 18 months, 2 years, whatever that time frame and evidence-based practice says that we should be following up. So that's kind of some of this is what we've seen as we've been doing it. And I'd love to hear what Dr. Greenaway thinks too.
Yeah, I mean, I think what we kept driving home is this is not just helping audiology practice at the top of our scope of practice, but really letting everyone in this system practice at the top of their scope of practice. We know our ENTs, our surgeons, they want to cut. That's what makes them money. That's what makes them happy. So what we are arguing kind of over and over again in this is, let us order that imaging. Let us have those boring office visits with the patients. Figure out who actually needs to see you, who has something actionable, and then you can spend your days, your time solving those problems. And we can do what is at the top of our scope of practice. We have very, very long, even in the Portland metro area, which is kind of our major urban area in Oregon, we have long wait times. Patients are waiting 2, 3, 4+ months to see ENTs when we make referrals. And that means that they're just not. I mean, when you're putting Medicaid finances, all of that even aside, just when you try to call and they tell you it's going to be November before you can get in, our patients aren't doing that. So we're failing our patients at patient care, not getting them care when they need it, but also lengthening the stress that patients, where we know we have patients where we look at them and say, you don't have a tumor, but we are following the gold standard. We're following our AAO referral guidelines. So I'm going to have you see this ENT anyway. That's drawn out stress for them. Like Arkansas, we also did a few different heat maps looking at audiology versus ENT. And that's one of the things that really drove home the need for this for me, was when we're looking, like Alicia was saying, specifically at neurotologists, otologists specializing in the ears, not just your everyday ENT. Outside of the Portland metro area, there are 2 counties that have neurotologists or specialist otologists. That's it. But audiology is not perfect in terms of rural coverage in Oregon, but we're doing a lot better than that. So for me, it was looking at how far are patients having to drive? Are patients even able to access that care? And pushing this legislation, if we had gotten that bill passed, it would have expanded quality care to a lot of patients across the state.
Yeah, I mean, I find this to be really interesting, ultimately, and I want to go back to what Kelley was saying about, how she had to really clarify this, that there wasn't some sort of monetary benefit to the audiologist. I mean, it seems like you're ultimately arguing to be, let us kind of unburden the system a little bit by being able to triage people more effectively. Let us be that initial point of contact. And then, we don't need to bog down these people that are already so in demand. Because that kind of seems like the nature of a lot of this right now is, we're just talking about specialty care right now, but in general, a lot of this seems like kind of a supply and demand thing where you have so much demand and just not enough supply. So it's a matter of figuring out with these smaller workforces that, kind of relatively speaking, how do you maximize them? And then how do you work in tandem with these sort of, ancillary or affiliated broader allied medical professionals? So I think it makes a lot of sense, but I kind of want to go back to this point to just talk about that piece that you described, Kelley, of, because it seems like that kind of gets at the heart of maybe what some of the if you're preemptively trying to get ahead of the opposition, right? It sounds like that might be one line, a through point in the opposition is that this is just to either creep on our AMA scope or something like that, or that this is going to somehow benefit the audiologist in some monetary way. So if you want to maybe talk through that a little bit, that would be great.
I think it would be interesting, especially for people that are listening and watching that are possibly going to work with their state. I think it is kind of interesting to hear maybe what opposition we each had to face. We had an AAO representative who also collaborated with AMA. And so we kind of knew both were coming at us. Straight up, we're worried that we were going to go purchase an MRI machine and we're going to do MRIs ourselves. So I continually had to say, no, I'm not interested in doing an MRI. I'm not interested in becoming a radiologist. That's not what this is about. So, we had to defend that. We had to defend health screenings, interestingly. That was something that they really came at us about. We ended up contacting our Arkansas Health Department, and this will be different in each state, I'm sure, but the Arkansas Health Department actually defines health screenings very broadly because there's all kinds of people in the state of Arkansas that actually do health screenings, from volunteers all the way up to professionals. And so we actually talked to the Arkansas Health Department and they said, do not change anything with the definition of health screenings. We are leaving it gray and we are leaving it vague. So we were able to come back against that opposition and say, even the state of Arkansas has most everybody doing health screenings. So that's not that big of a deal. We also had to change some wording as far as making all of the things that we requested, imaging, blood work, all that, pertaining only to the hearing and vestibular system. Again, actually said, we don't want you getting pap smears on your family members. We don't want you taking x-rays of people, your friends. And I argued quite a bit about that because I'm like, don't we all take an oath to stay in our lane? I mean, I would not expect my dermatologist to do a mammogram. We all as professionals, as doctoring professionals, we all stay in our lane, but they just wouldn't trust that we were going to do that. So that is the wording that we did come back and change for them to say that all of these that we're asking is only pertaining to the hearing and balance system, which quite honestly, you can relate just about anything that you want to the hearing and balance system. We finally decided that when we kind of got together, we were like, okay, well, I think we could probably write a report sufficient enough to relate about anything we wanted to do to balance and hearing. So yeah, I'm curious what other opposition the others had, but those were our main ones.
Alicia, Brian?
Oh my gosh, feels like forever ago. And so I'm glad Dr. Linton and Dr. Greenaway can remind me of all the opposition because I've tried to put it in the back of my head at this point. We had a lot of opposition around the word diagnose. They didn't, we had opposition that, audiologists can't diagnose, they don't have a medical degree. We weren't trying to maintain that we had medical degrees, but that was really at the core because we already had that in our regulations at the Maryland level. And we kept going back and saying, with all due respect, ENT or primary physician, if you employ audiologists and we cannot diagnose, we can't use diagnosis codes. Like, just think about that. If your clinical staff that's supporting you by doing auditory and vestibular testing can't diagnose that patient and use a diagnosis code, how are they billing insurance when there's coverage there? That was a big pause, thankfully. Yes, we fought health screenings for 2 years in a row because, just like Dr. Linton mentioned, for some reason, everybody thinks we're going to be doing UTI screenings, which was really interesting to us. We have a lot of really great memes around our legislative committee team about audiology doing UTI screenings. But again, we just went back to Medicare and said, Medicare is a government agency, or Medicare is a health insurance, approved by Congress, a government agency, and they are the ones instituting health screenings because they realize that providers are not talking to each other as they should, and EMRs didn't solve all these problems like they thought they were going to. And the patient needs to be looked at as a patient, not as an ear, not as a semicircular canal, not as a teeth and gum and tongue, and not as a kidney and liver. They need to be looked at as a whole person. And so when we went back and said, the FDA is very conservative, they gave the ability to prescribe and order prescription hearing aids. That would be the same for external devices around our osseointegrated and auditory implants. When we go back and say, Medicare, also very conservative, works with the older population, they're the ones saying that we should be doing this. The ICD-10 codes say that we're diagnosing. Are your audiologists diagnosing? Well, then why would you not let them diagnose in this statute? Like Dr. Linton mentioned, we did have to concede. And one thing that I would mention to anybody who's trying to push legislation forward, don't put all your cards on the table at the beginning. If you have nothing to compromise on, you are going to have to compromise on something, and what you really want is going to be taken out. So we had very vague things like cerumen removal. And now we have cerumen removal from the external auditory canal. I'd still like to know where the physicians think the cerumen is going to be other than the external auditory canal. But we also had to put in without the use of general anesthesia. Okay, we were good with that. That was true around our foreign object removals without the use of general anesthesia. Fine. We're staying in our lane. We want to stay in our lane, but again, we want to make sure it's very clear. And again, just like Dr. Linton mentioned, of course, we had to put in around auditory and vestibular related conditions when it came to kind of what we're calling those more advanced level practices the audiologist should be doing around ordering blood work, cultures, and imaging. So with that, I'm going to stop and turn it to Dr. Greenaway.
I think we hit a lot of the same kind of pain points. What I found really interesting was AAOH&S naturally wrote a letter of opposition, which we actually found to be a very friendly letter of opposition, if that's a thing. A lot of what they put in there we thought was thoughtful and actionable. And when we went back and did a proposed rewrite of the bill, we used a lot of the language they put in there. So our takeaway from that was we know they don't like it, but we don't think that they are as kind of staunchly opposed as we were thinking they would be when we started everything off. Our state medical association was a completely different beast. They just did some absolutely terrible rewrites. At one point, they sent us a version that would not let us diagnose or interpret results. So I had to go to their lobbyist and say, so what exactly, I'm going to do this test, and I'm just going to hand all these numbers to the ENT. Is that the system that you want here? And of course they said, no, well, no, that's not what we meant. But that was just a big mess. The other big roadblock that we hit, I would say two at the actual legislative side. One is we know that legislators and the general public are not well informed about audiology. I massively underestimated how little people know about audiology. Even in our Senate Health Committee hearing, the policymakers kept bringing it back to hearing aids, not understanding how this had to do with the dispensing of hearing aids, which we kept trying to tell them, well, it doesn't. It has the to do with the, I hate the term medical audiology, but the practice of medical audiology here. We're not just dispensing widgets. So I think that did put us back a lot. The biggest thing that what ended up killing us was we had a pediatrician on that committee who told me in a personal meeting that she just is not in favor of any bills that expand scope of practice for anyone. So that was kind of a dead on arrival thing. We did not expect that when we were coming into it. So kind of a lot of just education, I think, is where we're going to be starting off next time, and making sure that everyone understands what we do, what we're actually asking for, that we're more than just hearing aids. I think that's kind of going to be our launching spot next time around.
Okay, go ahead, Kelley.
Sorry. Oh, that's very interesting, Dr. Greenaway, because we did also have to learn which legislators were physicians. And we too had one or two that, well, one is married to a physician and one is a physician. And we knew that both of those would adamantly be against any scope of practice being expanded. So something that, again, another state that's going to be approaching this, that's good information to learn about your legislators, learn about your senators and your representatives, and kind of what they do and how they feel about certain things. Honestly, that's how Arkansas got it passed so quickly. We had a senator that was very much new audiology, very much supported audiology, came to us and said, what can I do for your field? What can I do for audiology? How can I help you? So he put us in, he didn't represent our bill, but he talked to, this is his third or fourth term. So he knows the people, he knows the other senators, he knows the other representatives. He talked us up and said, this is a great thing. This is a great field. This is what audiology does. Drug me all over the Capitol, introducing me, get a picture with this person, get a picture with that person, and I'm shaking hands and they're like, I support your bill. I support your bill. And I was like, do you want to hear about the bill? No, because he's already told me about it and I support it. So it's that kind of an environment. And I didn't anticipate that kind of an environment going into it. But after we were in that environment several times, I was like, okay, this is the key, because when I was gone, or when we were gone, he's still talking about audiology, and he's still talking about the importance of this, and answering questions, why did you not pass it, or what do you have against it? Then he would contact me and say, this is a doctor, he's not going to pass anything because it's scope of practice, so don't worry about him. Now let's talk to these people. So, and I know we used no lobbyist. We had no lobbyist in Arkansas. We did it all on just relationships, our personal relationships with our senators and with our representatives. So I can't stress that enough.
Yeah, I would say that is a big piece of advice that Dr. Spoor gave me early on, that we unfortunately just ran out of time before we could really nail down, was don't just find a sponsor, but find a champion. Somebody who's going to really stand behind your bill and stand behind you, because there will be times where it gets ugly and you need somebody in your corner for that.
The other thing I want to mention is not all AMA and not all AAO-HNS physicians are against what we're trying to do. And we had a physician on both committees, our Senate and our House side. We knew the senator was only speaking on behalf of AMA, and that was going to be an issue, but he was one of 9 that we needed to work with. So as long as we could get to the other 8, we were okay. But it turns out the physician on our house side, once she heard it, she's like, oh, well, can't you guys already do this? Why don't you just start doing that? That's not a big deal. You can do this no without any problems. Like, oh, you don't need to put that in legislation. Just go out and start doing it. I like that idea. I also want to make sure I'm not going to lose my audiology license if somebody comes back to me. But I would say that was true for our boots on the grounds too, because we all have physician relationships. They need us, we need them. And so we went to those ENTs or those nurse practitioners or those neurologists or those neuro-otologists. Not all of them would support us. Not all of them would support us publicly. But we went to them and said, hey, this is what we are doing. If they're working within audiology space at some point, they understand why. You didn't have to explain that to them. Some of them are very much willing to put their name and their face and their reputation on the line for the audiology profession. And those people are also very key in what you're doing. And again, does not have to be ENT specifically. Those primary care physicians are overworked. Those pediatricians, even though one of them in Oregon does not understand, those pediatricians need the help. The dermatologists need it. The neurologists need it. Our nurse practitioners in the state of Maryland, totally on board with what we're doing. And those are people who are working clinically, and those are the educators as well. Turns out we could get our radiologists on board as well. And so don't just think, oh, physician means you're going to be against me. That's not true. And don't be afraid when some of the physicians will say, I can't do that. Right? Or I'm not willing to do that, even though I support what you're doing. One other comment really quickly on that. I was very surprised at the audiologists who came back when we put our legislation forward and said, I don't feel like I'm trained to do that. And that was a big wake up call for our state association. And it was a big wake up call that we mentioned to our board of examiners. Some of these audiologists that you are licensing are very clearly stating that they don't feel that maybe they were trained or they were this or they were that. So we had to work a lot around continuing education. This is what accredited AUD programs have to provide. And again, I'm not saying right or wrong, but most of our opposition came from audiologists if they were opposing us who happened to be employed by an ear, nose, and throat specialty clinic. So we got out ahead of that a little bit more. We made sure those relationships were a little tighter when we were talking to people. And it was very easy to say, follow the money sometimes. And I don't mean to point that in a bad way. We can take all those comments out if we want to in the final editing. But I do want to say it's not always opposition from the outside. You also have to be ready from opposition on the inside, both from individuals, and we had opposition from our audiology professions as well. And so, again, big wake-up call for us when we were doing that.
I would concur.
I will just say that I really have enjoyed this conversation because I feel like we're getting to, I think, some really valuable information for people that, again, in the spirit of like, how do we get more states and more of a grassroots presence, and more people to get involved. So I want to bring Steph in here. I feel like she's been patiently waiting on the sidelines. But I wanted to talk about, we've talked a lot about the what and the why and some of the different how, but, I really do want to talk about ADA's role here. I know that you've been involved with all three of these different groups in each of these states, but for me, I just keep thinking about again, we'll just use like Missouri for example, is if I were a young audiologist that was wanting to get more involved, what does that look like? What are some of those early initial steps that states can be taking? I think there's so much information here about tactics around, you really need to identify methods in which you can build relationships or identify people that maybe you have mutual connections with and start to build inroads there. Do your research to understand who might be favorably, or have a favorable opinion of what you're proposing. But anyway, Steph, I want to give you a chance to kind of chime in here and talk about the role that ADA has been playing and how you see that serving as a sort of support, infrastructure for these efforts.
Yeah, thank you. ADA has had the honor of being able to support these different endeavors and other endeavors that are in the works that are similar that you'll probably hear about in the near term. It's very much a supporting role. So I think my first advice to somebody who wants to do an initiative at the state level that's going to modernize their scope of practice would be to either join their state association or form one if one doesn't exist. Because you have to, at a grassroots level, you have to get to know the people in your own community, both from a stakeholder standpoint, whether they be opposers or supporters, but also from that legislative framework. And every single state operates and functions differently. I also would say that this isn't an overnight situation. Okay, you're going to have to cultivate some of these relationships, sometimes over a longer period of time. I think, in the case of Maryland, which I do happen to know better than others, I know that their progress really started 30 years ago. So what looks like an overnight success was really about 30 years of building relationships in their particular case and failing a couple times. Arkansas, as Dr. Linton mentioned, had a benefit of having a senator that had a keen interest in some of the things that they were pursuing. So they were able to speed up a little bit what they were doing, but they still had to work very diligently with their stakeholder community, with the legislative community. And I think one of the takeaways, if I'm not mistaken, in Oregon, is that some of those relationships have yet to be fully cultivated, that this is kind of a starting point. But I think people should have a little bit the expectation that you're not going to succeed always the first time out of the gate. And what looks like an instant success is really the tip of the iceberg. You're not seeing the rest of it underneath, which was all the years of cultivating these relationships, right? So again, first thing, start with your state association, join it. Second thing I would say, definitely we think you should be involved with ADA because regardless of whatever your practice setting is, ADA is the organization that is dedicated to the autonomous practice of audiology and evidence-based delivery of hearing and balance care, which means aligning your education and training with your scope of practice. And in most of the states that we've examined, there's a huge gap or a huge disconnect between that. A lot of these state statutes haven't been updated in decades. Okay, so as Dr. Spoor mentioned, one of the impetuses for us really taking a new look at this, a fresh look at this, was the FDA final rule on over-the-counter hearing aids, which created this prescription hearing aid category, which necessitated ensuring that audiologists are able to prescribe prescription hearing aids. I can tell you that today, there's still over half of the states where that is not expressly stated in statute. So there are a lot of states that actually need to be remediated right now, that need to have their scope of practice or their audiology statute opened up for no other reason but to add prescribe as an activity that an audiologist can do. And that doesn't mean that we're actually fearful that anyone's going to go after someone's audiology license because they have been prescribing for all of these great many years, right? But what we do know is that insurers are increasingly scrutinizing practice acts to make sure that what they're paying for is something that aligns with the statute for that particular provider type. So we want to make sure that audiologists are protected and able to continue to be reimbursed for the things that they're doing, that they've been doing for all these decades. By the same token, though, unfortunately, in the broad audiology community, for the past 40 years, while audiology has progressed significantly from an educational standpoint, moving from a master's degree to a clinical doctoring degree, from a scope of practice standpoint, the biggest achievement before these achievements in the past 40 years, or the biggest effort, was really applied towards expanding audiology scope of practice backwards. You're going to say, well, why? What do you mean by that? Well, audiologists have dedicated the better part of their advocacy initiatives at the state level, getting rid of dual licensure requirements that would require them to be licensed as a dispenser and an audiologist in order to dispense hearing aids. dispensing hearing aids, by the way, is something that in most states an 18-year-old can do with a high school diploma and no post-secondary education. So we spend an awful lot of time, talent, and resources to expand scope that way, and have neglected to do the things that need to be done to really modernize it to align with the education and training that has been pushed forward. So it's been a wonderful opportunity to take a look now at what the FDA has done and the need to open all these statutes. And in some cases, again, we're going to have to remediate other things, like Dr. Spoor mentioned, making sure that cerumen removal and cerumen management is in scope of practice, making sure that vestibular assessment and management and rehabilitation is in scope of practice. There are still a couple of states out there where you actually have to have a physician referral to do vestibular services. That's insane at this point. So we need to do that type of remediation, but then also fully modernize to include things like ordering imaging and ordering blood work and other tests that are really going to speed the process for the patient, keep the patient in the continuum of care. Audiology is not looking for opportunities to go it alone. We're looking for opportunities to more seamlessly integrate patient care with the other specialists so that the patient is getting the services that they need when they need them and not falling out of that continuum altogether. So I think that's a really important point. I also think that we have to look at building statutes that are going to be in containing the activities of the future. So we want these things to be broad enough so that as new technologies emerge and as new protocols emerge, that audiologists don't have to go back every single time and reopen statutes, right? So including things like assess, evaluate, diagnose, manage, treat, all of these things that are broad enough to encompass a great many things as we go into the future, I think is fundamental. And that's probably the number one thing that we're looking at as we look at these statutes now. Now, what ADA has been able to do that I think from a support standpoint has been really useful is we've been able to connect the dots a little bit. We've been able to do some research that's deep and far-reaching that sometimes volunteers at the state level don't have time to do because they are practicing in the clinic all day, right? Helping their patients. We've also been able to see sort of what's working in one state that could be applied to another state, or what changes might we recommend based on the success or inputs from a state that could be helpful to another state. So we've been able to sort of serve as maybe a connector so that states that are interested can talk to states that have done things in a more seamless fashion. And then I think we've been able to also start to look at things in a way that's a little bit predictive, in that one of the things that I noted in Arkansas, for example, is that Arkansas is one of like 12 states that have the most generous scopes of practice for optometry in the whole nation. In fact, in Arkansas, optometrists can do LASIK surgery and some other pretty sophisticated and advanced procedures. So if you consider that audiology is to the eye, or audiology is to the ear, what optometry is to the eye, you can see that what we're asking for, what we did ask for in Arkansas, is extremely conservative, right? By comparison, and extremely reasonable. But what we found out that's even more important than the fact that optometry achieved these things is that many of the legislators that voted yes for optometry to be able to do those things are still in the legislature. So it makes that a kind of a perfect place to look at. So now what we're doing is assessing sort of all of the different state practice acts outside of audiology. As Dr. Spoor mentioned, we're looking at optometry and chiropractic and dentistry and podiatry and physical therapy and others to see what is everybody else doing. And if they're all clinical doctoring professions, then why isn't audiology more aligned with those? And surely the legislators that supported, modernizing those scopes of practice would also be keen to modernize audiologies. So we're trying to look at it from that perspective. And again, we've made reasonable asks in each of these states that are consistent with the education and training that audiologists already receive. So this isn't an aspirational modernization here. Nobody's asking to do surgery. Nobody's at this point is asking to prescribe drugs or other things, right? So maybe 20 years from now, when the education aligns with that, I'm not saying that's not something in the distant future of audiology, but right now we need to get the practice of audiology and the scope of practice of audiology to align with the education and training of audiologists. And that's, that's what we're all working to do. The other thing that I have found is all the people on this call right now are ADA members. I have found that the generosity that ADA members have is limitless when it comes to helping other ADA members or other states do things. And it's really that I think puts ADA in a little bit of a unique position. These are all people who are really busy. These are all people who dedicate a lot of time in their own clinics and their own businesses in a lot of cases. But these are people that I have found to be some of the most generous in the entire profession of audiology and willing to even travel to each other's states to testify or to do things or to write testimony or to help. And I think that is something that's fully necessary if we're going to advance an entire profession and professional care. Now, all of this aligns with the initiative that ADA has been working on called Audiology 2050. You can find it on our website. But really, the fundamental principles of that have patient care and patient well-being at the core. So this whole initiative begins and ends with patient care and expands out from there. And we believe that key evidence-based practices are the things that we're working on when we work to modernize these state statutes. So it all comes back full circle to help the patient and meet the patient where we are. And the other thing that we're really trying to encourage all of our members to do is to really start higher up the continuum of care, right? We all should be doing preventive care at this point. And I think that's another way where we're kind of looking from a clinical standpoint to try to align with some of the other clinical doctoring professions like dentistry and optometry and others in that realm of prevention. So you're going to see more of that out of ADA also.
That's wow. Fantastic overview there. I think that really describes what the role that you all are playing in kind of the common ways that I guess people are leveraging your resources. So it's been an amazing discussion. I've personally learned a lot. This has been a great forum for learning. So closing thoughts as we kind of wrap up here. We'll start and end, I guess, same way we started. Alicia, you can close us out with your first thoughts.
Oh my gosh, I need to think on this for like 30 seconds. I'm going to give Dr. Greenaway and Dr. Linton a chance to chime in or to think as well. I want to say something that just reiterates, right? Nothing happens overnight. I guess my big thing that I would say is that obviously relationships are important, but this was an effort. And Stephanie Czuhajewski has heard me say this kind of tongue in cheek. I am still happily married. I feel like I gave up my marriage to get this piece of legislation passed in 2024. Nights were easily spent until 2, 3, 4 in the morning. Emotions got very high at many of times, which you really have to keep in check. There were many screaming matches. There were many times where it was like, we can't do that, but yes, we can, but you got to think about this. And what are we going to do? And the legislative team bore a lot of weight on our shoulders for that because we thought if this doesn't pass, which it did not pass in 2023 when we initially put it forward, that we were going to let down the profession of audiology. And then where were we going to be? Right? We see this as audiologists can continue to be audiologists, where some of us were thinking if something doesn't change, audiology is not going to be around in 10 years or maybe even 5 years because of what was just said. If you just want to fit hearing aids, why do you need an 8-year clinical doctorate degree? And so the amount of time and effort and stress that came with it is easier when you have multiple people working on it. But if you are thinking of doing this, please know that we are all on your side and here to be your therapist and help you along the way as well. So I'm going to stop there and let Dr. Linton go, and hopefully she has some more elegant ways of final closing.
Well, I concur with a lot of what you said as well. It's funny, 2025, I started 2025 with this is the year of no, because I've been practicing over 30 years now and I'm pulling out of patient care. And I said, this is the year of no. until this came along. And I was like, okay, I'll do this one thing this year. Wow. I didn't know I could drive to Little Rock that many times in a week. Little Rock's about a 5-hour drive round trip for me. And it was day after day after day. In fact, sometimes I just spent the night in Little Rock because I knew I was going to have to be there for another meeting, sometime the next day. And when this bill is going through and they rewrite it and then they're going to put it in committee again that evening, it's your schedule just has to be very flexible for that. I would say along the line of relationships, join your state organization, join your state audiology academy, or create one if you don't have one, just what's already been mentioned, and learn who in your state is an advocate for this, because really everybody isn't. It was already mentioned earlier, I was also shocked at the number of audiologists that opposed us. And we got calls like, what are you doing? Why are you doing this? What are y'all trying to do? Are you trying to run our scope of practice in Arkansas? And I was like, okay. So educate the ones that are out there, leave the ones that don't want to work with it. If you can't change their mind, you get the powerhouse people that do get behind it and do understand it, and then make those relationships with your legislators, your senators, and your representatives, and educate as to what audiology does and what we're needing to do. And that also goes on the national level. I was also surprised at the lack of support that we got nationally. ADA, I can't even say enough good things about ADA. We talked about needing a heat map. I mean, how many ENTs are there? How many audiologists in the state of Arkansas? We know we're rural. And we all looked at each other and went, well, yeah, that'd be really nice if we had one. ADA got it for us. Just like Stephanie said, they've got time to do those things that we knew we needed, but we didn't have time to figure it out. ADA was there. They supported us. They showed up. They talked. They were sat beside us in testimony time. They were right there with us. And every national organization did not do that. So go ADA.
Brian, closing thoughts?
Yeah, I think my takeaway, even though we didn't get it done this time around, is I'm still just feeling unbelievably positive and just kind of charged. I've been working in legislation and policy and audiology for 6 or 7 years now, and it has been 95%, I think, other than working on Maya and its precursors, always have been working kind of on the defensive, protecting patient safety, fighting against inappropriate scope creep. The fact that we are not only in Oregon, but just across the nation, getting to be on the offensive for once, getting to do something that is forward-looking for us, really impactful for our patients, is just really charging and engaging for me. And I'm hoping it will bring in not only more members to our state organizations, but more people who will raise their hand and say, yeah, I have an hour a week to volunteer, 2 hours a week, because that's what we really, really need. We need people who are going to put their boots on the ground and talk to their senators, knock on doors. This is a huge, huge moment for us. I think we're kind of have the opposite mentality of, again, from when we were playing that defense, you always have this thought of, well, if we let this happen in our state, then it's gonna spread like wildfire everywhere else. Thanks to the amazing work of Dr. Spoor and her team and Dr. Linton and her team, the fire started. So it's not an if, it's a when now. So we just all get to ride that wave and see this move across the country and really push forward and push towards the goals set out in that Audiology 2050 ADA initiative. So I'm very, very, probably the most excited I've been in advocacy and audiology in quite a while.
That's really good to hear. Thanks, Brian. And last but not least, Steph.
Thank you. One of the things that Dr. Greenaway just said sort of sparked something for me, and that is, I can't speak for everyone in this room today, but I will probably not be working in audiology in 2050. Okay. I think this is going to come to fruition and it's all going to be great. But one of the things that I was so impressed about is the number of young people who came out to support what we were doing. And in particular in Arkansas, we had students come out from UAMS. We had a student testify. at both of the big hearings that we had. And what it demonstrated for me is you always wonder and hope, is the next generation going to take up the torch and are they going to continue to run and drive the profession forward? I can tell you that I have seen firsthand that that is definitely going to happen. And like Dr. Greenaway, I am more encouraged and excited about audiology than I've ever been. And that's saying a lot in these 17 years that I've been working with ADA.
That's awesome. Well, I couldn't have picked a better panel myself. This has been really fun. I really enjoyed learning more about how this whole process has worked, the inner workings of it, the results, what it means to come up short, and then you go back to the drawing board and how you would maybe succeed the next time around. So I feel like the way forward is for more collaboration. So kudos to ADA for really, kind of embodying that spirit of collaboration and helping these state organizations. I mean, it's a small workforce, but it can be small and mighty. And I think that you're all sort of evidence of that, even if it means like you, Alicia, and you, Kelley, and I'm sure Brian, you too, of all the long nights and hours that you've put into this kind of thanklessly. But know that there, I think, are tons and tons of us out there that are looking on with admiration and cheering you all on and thinking that it's really inspiring. So with that, we'll close this out. Thanks for everybody who tuned in here to our virtual panel at the Future of Hearing Healthcare Conference, and we will see you next year. Thanks.